So to set the stage for today, I wanted not necessarily to overwhelm you with information, but to share with you a little bit about why race is a particular important topic in multiple myeloma. We have a disease that, first of all, is the most common hematologic cancer in African Americans. Now, generally, myeloma is not a very common cancer. As I'll share with you later, it accounts for about 2% of all cancers, but it does account for many more within the African American community. So currently, the African American community comprises about 14% of the total population, and yet nearly 20% of all myeloma patients, and it's expected over the next 10 years that that will increase to 24%. So what I'm going to share with you are just some very simple, straightforward facts with little commentary at first, because we're going to dive into the commentary later and how we want to deal with some of these facts and overcome, if you will, some of them. But I think understanding the framework in which we work, understanding how significant this disease and the burden that it is within all patients, but in particular the African American community, is important. So we're going to hear a little bit later about MGUS. So MGUS is the precursor or the precondition, what people have before they have myeloma, when they just have this abnormal protein in their blood that's not hurting them yet, but unfortunately that develops into myeloma. And MGUS, we know, unfortunately, is really common. In fact, in probably 5% of people over the age of 40, we've heard already that Kelly's barely over the age of 40, but for all of us over the age of 40, about 5% of us will have this MGUS. Now, a small fraction goes on to develop myeloma, but that fraction of patients who have myeloma is twice as high in the African American population than it is in the white population. Thirdly, when myeloma is diagnosed, it's diagnosed 4 or 5 years younger in the African American population. And this becomes important because sometimes, as we're going to be sharing with later, this diagnosis can be missed or ignored for a period of time. I was sharing with our team yesterday that a recent study in England showed that most myeloma patients get seen by their family doctor 3 times for different symptoms before the diagnosis is made. And so we're going to be talking a bit more about the importance of that earlier diagnosis. So if we look at that age distribution, as I say, the average age for African Americans is about 65. It's even a little bit younger in Hispanic Americans, and the average white patient is diagnosed at 69 in Asians. Unfortunately, although we're going to get excited today, and in particular, Dr. Badros is going to share with you some of these exciting new therapies that we have in myeloma, we've seen great improvements in survival in myeloma. When Dr. Badros and I started in this field, and I've had the privilege of working with him for over 20 years, most of our patients sadly didn't live maybe 1 or 2 years. Now we're pretty much close to 10 years being the average survival. Obviously, we want it to be longer than that, but that's a huge advance. The problem is, for every 1.5 or so years gained in the white population, only about half of that gain has been seen in the African American population. This is really the most daunting stat that I'm going to share with you today. And it's important to think about, why is that? Why has the improvement not been seen in this population? Well, there's lots of reasons. I'm going to suggest, first of all, that there's a longer time to diagnosis from the onset of symptoms. I was mentioning that earlier, that often patients spend a lot of time talking to their doctors or experiencing symptoms before they're diagnosed. That's true of all myeloma patients, but it's particularly true of the African American population, even longer. Sometimes the doctor may think, oh, this may just be diabetes, or this may be something else, or it's not really myeloma, and they may miss that diagnosis, which is why, as we're going to share with you later, part of our Empower project, that's what the phrase we use, which stands for Myeloma Power. We're trying to empower people to change the course of myeloma, as I'll describe earlier. Part of that change is to have primary care doctors make the diagnosis earlier and more accurately. You're going to hear from me and Dr. Badros about the importance of what we call triplets, or 3 drug combinations that we use for myeloma. This is part of the reason why we've seen people live longer with myeloma. Unfortunately, African Americans are less likely to receive those triplets. And that's another reason why we've not seen the benefit as much in the African American population as we've seen in the white population. Secondly, they're less likely to receive stem cell transplants. I talk about the 3 T's, triplets and transplants is number 2. And stem cell transplants is a feature that or a process that we're going to describe in a little bit that helps us control this disease better, where we are able to give a high dose of a certain chemotherapy drug to control the disease, and then we grow a new bone marrow in a patient. So we'll describe a little bit of that later, but this we know has had an impact in improving survival in myeloma patients, and unfortunately is less accessible to the African American population. And then thirdly, we said triplets, transplants, trials. So as I mentioned, if African Americans comprise nearly 20% of myeloma patients, at best, they may represent 8% of patients on clinical trials. Now, clinical trials are complicated and carry sometimes a lot of challenge and discussion, but we know that clinical trials have saved lives and prolonged lives as we introduce some of these great new drugs that Dr. Badros will be sharing with us in a few moments. And so it's very important for us, I think, to appreciate that this is a big disparity in what we do in multiple myeloma. And we want to think a little bit about why that is and what ways we can overcome that and provide the opportunities for better care for our patients, for all patients, independent of their race. Number 9, so we had 10 big facts here. Fact number 9 is that there are some biological differences that interestingly show, as we're going to be hearing a little bit later, myeloma sometimes we describe or divide into 2 groups. About 25% of patients have what we call high-risk myeloma, and about 75% of patients have standard risk myeloma. And we know that that is basically defined by what we find in the cancer cells themselves that live in the bone marrow, what are called the plasma cells. And we look at the genes of those plasma cells, and some of those genes point us in one direction or the other. So there's something relatively common called translocation 1114 or T1114. Just means like a little chunk of chromosome 11, a little chunk of chromosome 14 joined together. That's more common in the African American population. And historically, people do better with myeloma when they have that. And yet it's less common for African Americans to have what's called the 17p deletion, which is where you're missing a part of chromosome 17. And that usually is associated with inferior or poor outcomes, or people live shorter lives, unfortunately, when they have that. And that's less common in the African American population. So you would think that outcomes in patients with who are African American would be better. But as we mentioned, because of the lack of access, because of later diagnosis, that's not true. But let me end on a positive note for this first section, which is that we do have evidence from VA studies and others that if patients are given equal access to their care, where they have access to the triplets, transplants, and trials, where they are cared for as with others of other races, we know that their survival can not only be as good, but in fact better. And that's the mandate we have today. That's our call to action, is that we have to do something about this. It's unacceptable. The current course of myeloma is not acceptable, and we want to do something to make it better. So my last slide in this first section is, what are we going to do about this? Well, in a 2.5-hour workshop, we can't fix everything, but we think of it as in sort of 3 layers. That there's what we do within the general community, what we do in the medical community, and then what we do in the corporate and in the regulatory community. So in the lay community, or in the general community, we want to do things like this workshop, where we want to raise awareness, give good education, advocate for patients, empower patients and their families to understand this disease. You may be here today and having some of the signs and symptoms we're going to talk about later, and maybe it'd be important for you to talk to your family doctor about that, because I'm not saying you have myeloma, but you may have myeloma, and we don't want it to wait and get worse before we finally make the diagnosis. We want to engage that community so that they can work with us to better outcomes for patients. In the medical community, we need to educate people. We need to develop cultural competence so that we can learn to better care for people of all races and backgrounds, and improve access, especially in myeloma, to those triplets, transplants, and trials. And then even beyond the scope of today, but we are pushing our regulatory authorities and the companies to really think about this and say, how are we making sure that African Americans are included in clinical trials? How are we making sure that the structural phenomenon of our community does not create a barrier and at times racism that sadly affects the care and outcome of our patients? And the only way this is going to happen is with a collaborative effort of all of us together. So the IMF has created this African American initiative, which you're going to hear more about today, when our goal is to improve the short and long-term outcomes of African American patients, working in the 4 areas that Kelly mentioned. For the last 30 years, we've been involved with, over 30 years: awareness, education, support, and research.